What I'll do is I can re-record this little section too. I'll
Oh yeah. I mean, I don't care. I wrote it down anyway, but I was just asking.
I did forget to hit the record button.
And did
So
you
hello
also?
everyone. Um,
Okay.
um, so what happens from here is that once the muscarinic antagonist block the the receptors, over time, our body will start to replace the acetylcholinesterase that's been inhibited, and it will recycle these. And then eventually, what's going to happen is that we get our our acetylcholinesterase back. And what is that revived acetylcholinesterase going to do? Well, it's going to start to break down the excess acetylcholine. And then that's how we're going to stop. That's how the cholinergic crisis eventually stops. Is that we prevent the stimulation of the nerves and we wait for the body to start recycling the enzyme and start killing the excess acetylcholine.
But how do you recycle it?
The body does it automatically because, like any enzyme, is just proteins. So, over time, those proteins break down, they fall apart. And so our body is constantly recycling these enzymes. These enzymes might only be around for a few days at a time. And so what happens during cholinergic crisis is that the body is under such amount of stress from the constant stimulation that it can't really focus on recycling the enzyme. So by administering the muscarinic antagonist, we're kind of helping the body recover so that way it can start to recycle what it needs to. So you might be administering the muscarinic antagonist for a couple days, 3, 4, 5 days in order to get the body to give the body enough time to start rejuvenating that acetylcholinesterase.
Yes.
The There is another antidote that is a little bit more straightforward, and I think it's a fairly new one. I can't remember. It's called praladoxime, or its brand name is Tupam. And praladoxime is a acetylcholinesterase reactivator. So, just like what it sounds like, is that instead of administering the muscarinic antagonist, we can administer praladoxime and it will just turn on the acetylcholinesterase again. And then it will start to reduce the cholinergic crisis.
Sorry.
No worries.
Was it?
So,
So
once
it's
again,
mhm.
there's another drug called praladoxime, and praladoxime is an acetylcholinesterase reactivator. And so, what it does is that uh, when there's inhibited acetylcholinesterase, what it does is it comes in, kicks off the inhibitor, and turns the acetylcholinesterase back on. And so what that will do is it will start to break down the acetylcholine. It will start to decrease the high levels of it, which will decrease the hyperstimulation.
I think I was like a little bit confusing between when you say less hyperstimulation. So for the cholinergic crisis, there was um, acetylcholine esterase inhibitor, right? Which
Yep,
is lead to hyperstimulation since there will be no like kind of less breakdown, right?
correct.
For muscarinic antagonists will be just uh, how do I say it? Since they're like blocking with the receptors, so it's going to be less hyperstimulation, and that is kind of similar to pralidoxin.
Yeah, so essentially the way to think about it is that we can either administer a muscarinic antagonist, which just prevents the acetylcholine from just stimulating. So we're not as the muscarinic antagonist isn't decreasing the concentration of the acetylcholine. It's just waiting. It's just blocking its potential. And then over time, the body will start to break it down once it recycles those enzymes. Or what we can do is administer pralidoxime, which will start to immediately start to break down that acetylcholine. So it's two different mechanisms, two different ways of attacking the hyperstimulation. One is by preventing stimulation, and the other one is by increasing the destruction of the acetylcholine.
I think I actually understood the muscarinic antagonists as the blocking meant be destruction, but then how does it differs between the preventing and the increasing destruction?
Yeah.
I
So
feel like it is kind of similar.
it's incredibly similar. So it's just two different ways of doing it. Essentially, what it is that for the muscarinic antagonists, they just like you said, they block and then we wait for the destruction of the acetylcholine. Versus for pralidoxime, what it does is it just increases the destruction from the get go. So it's two different ways of attacking the same problem because ultimately we need to start decreasing that acetylcholine. Ultimately, we need to get here. And so muscarinic antagonists block and then allow the body to catch up versus the pralidoxime just does it right away by reactivating the enzyme. Does that make sense?
Yes.
Cool.
Thank you.
The other big thing to know, and this is a little bit more of therapeutics for you, is that in general, we can use the muscarinic antagonist for either the organophosphates or the acetylcholinesterase inhibitors. We can use it for either one. Versus pralidoxime is, I believe, almost exclusively only for the organophosphates. But remember that these two things basically act the same way. So because of that, we can essentially think of muscarinic antagonists and pralidoxime fixing cholinergic crisis as the same thing.
Yes. Thank you.
All right. How do we feel about this? Good?
So far, so good.
All right.
Yes.
Let's jump into our next section of drugs, which we're going to be tackling kind of sort of similar how we went through the nicotinic drugs, very, very slowly so that way we could understand them. For our next section, we are we're going to go through it's a very diverse section because we're going to be tackling a lot of drugs that you would have seen in the top 200. But what's also important to note is that the beta agonists, the alpha agonists, and the rest of these drugs as well, primarily these first two sections are pretty big and are prescribed a lot of the time. And we'll see why. But the big thing is we're going to take this nice and slow and we're going to kind of look at it in a very, very central way. So, without further ado, let's talk about these drugs. Now, I do want to start off and start us back up at this picture of the nervous system so we can see where we are. So, we have talked about the parasympathetic pathway and how the muscarinic agonists and the muscarinic antagonists can change the parasympathetic tone of the body. On Monday's recording, we talked about how the nicotinic drugs can affect the skeletal muscle, as well as uh, we have nicotinic agonists like varenicline or nicotinic agonists like nicotine, which affect the autonomic nervous system. But what we really focused on is with the neuromuscular blockers. So when we talked about, the pancuronium, the vecuronium, all those different things. So that's where we've talked about so far. We've talked about the muscarinic agonists and the antagonists, and we talked about all those neuromuscular blockers. What we're going to go into now is we're going to talk about the sympathetic pathway. And we're going to look at all the different drugs that affect these alpha and these beta receptors. Now, what's important to know is that there's two different kinds of alpha receptors, alpha 1 and 2, and there's three different kinds of beta receptors, beta 1, beta 2, and beta 3. And we'll take a look at these more in depth in a second. But what's important to note is that both the alpha and the beta receptors are both stimulated by norepinephrine or epinephrine. So once again, what did I just say? What we're saying is that the sympathetic nervous system, its postsynaptic ganglia release norepinephrine and epinephrine onto adrenergic receptors. And what we're about to look at is all these different drugs that affect the alpha receptors and the beta receptors. So without further ado, let's jump right in and let's take a look. We're going to start our journey looking at the beta receptors. And the beta receptors, oops, looks like all my pictures didn't get put in. The beta receptors are divided into three different subtypes. We have the beta 1, we have the beta 2, and the beta 3. Primarily, we're going to focus on the beta 1 and the beta 2 receptors, and we'll talk about beta 3 a little bit later on. But the reason why we're focusing on beta 1 and beta 2 is because beta 1 focuses on the heart and the kidneys, and beta 2 focuses on that smooth muscle. And when we think about the heart, kidney, and smooth muscle, we should really be thinking about blood pressure and the cardiovascular system. And so, what that reveals about the beta receptors is that they innervate and control a lot of the blood pressure in our body. Likewise, the beta 2 receptors also innervate the skeletal muscle, the liver, and the eye. And so, by looking at these locations where we find the beta 1 and the beta 2 receptor, we are going to be able to see a lot of the major effects of either activating or inhibiting the beta 1 and the beta 2 receptors. Uh, Let me normally have a nice lot of pictures, but for whatever reason, um, all my pictures didn't get put in. Maybe we'll be okay. Our first set of drugs that we're going to look at are the beta 2 agonists. And when we think of the beta 2 agonists, we should uh, look at a lot of what am I trying to say here? We can look at a lot of the different effects that activating the beta 2 receptor does. And so you might recognize some of these drugs over here: albuterol, the levoalbuterol, maybe the vilanterol or the formoterol. You might recognize these as they're all inhalers, right? They're all something that a patient would inhale into the lungs. And what we'll notice is that it by inhaling these beta agonists, we start to see dilation of the smooth muscle. Or in other words, we're relaxing it. And what we see is that we have vasodilation and bronchodilation. Now, what's important to note is that when you vasodilate, what's going to happen is that we're going to drop the blood pressure. So let's make a little drawing for us. Is this? No. So what we're doing is we're taking our blood vessel, we administer our beta 2 agonist, and we're going to dilate the blood vessel. And if we look at what's going to happen to our blood pressure, well, if we increase the diameter of the vasculature, we're going to drop our blood pressure. And by this sudden drop in blood pressure is going to cause the heart to start beating faster. So our heart rate increases. And this response of the heart reacting to the drop in blood pressure is something called reflex tachycardia. So once again, we administer a beta 2 agonist like albuterol. It causes vasodilation of the blood vessel, which leads to a decrease in blood pressure. The body responds by increasing the heart rate. And what that increase in heart rate is going to do is it's going to try to bring that blood pressure back up. Now, if we think about this, is this very useful to someone who has heart failure? No, right? If we're talking about someone, if we're trying to give someone with heart failure albuterol inhaler, then what we're going to do is we're going to make their heart beat faster. And that's not anything useful because we need to control the heart rate in heart failure. And so one of the big things to know about uh, whenever we have these beta 2 agonists is that they cause that reflex tachycardia. Like we said too, is that the vasodilation of uh, the vasodilation of the sorry that the stimulation of the B2 the beta 2 receptors causes bronchodilation. And what's important to know about the beta 2 receptors is this is the most important effect of the beta 2 agonists. And it's the primary reason why we use them. So if you have someone with asthma or COPD, which have very constricted airways, then administering a beta 2 agonist causes bronchodilation. And so that widens the airway and allows for the patient to breathe better. And so they can get more airflow in and they feel better. Sure. So the question we got is what is the difference between heart failure and heart attack? And that's a good question. So heart failure is a um, heart failure is a weakening in the ability for the heart to contract. So for whatever reason in heart failure, the heart doesn't contract. Heart contracts slower. It contracts weaker. And what this culminates in is an inability for blood to be pumped across the body. And the big thing to understand about heart failure is that we're not talking about the heart not beating. The heart is still beating, it's just beating slower and it's beating weaker. Now you can have arrhythmias which cause a disturbance in the ability for the heart to contract and the rhythm is all off. But in general, in heart failure, what it is that the heart is trying to work so hard in order to get blood to where it needs to go that it starts to become weaker and weaker and weaker. And so the reason to quickly go over what a heart attack is, let's try spelling heart correct, or that myocardial infarction. Let me see if I can. What a myocardial infarction is it's a occlusion of the uh, it's an occlusion of the blood vessels that flow and feed the heart. So what happens is that some sort of plaque buildup in the heart prevents blood flow, and then that causes the heart to die. That causes the tissue to start to die. And so what happens in a heart attack is your heart stops beating and it's no longer beating at all. And that's the big difference between a heart attack and a heart failure is that heart attack is the heart stops beating. And whereas heart failure is caused by the natural usage of the heart that over time it becomes weaker, a heart attack is caused by that occlusion or the inability for the blood to um, oxygenate and feed the heart. So that's the two differences between heart failure and heart attack. And so when we think about the beta 2 agonist, why it's not beneficial to give it to someone with heart failure is its main effect is that it causes this reflex tachycardia. And if the heart is becoming weaker because it's doing too much work and it can't keep up, and so it's getting old and it's getting tired, then trying to cause it to work even harder is not beneficial. So, once again, when we administer that beta 2 agonist, we cause the heart to beat faster. And that's not beneficial for heart failure because we're going to cause the heart to work even harder and the heart can't keep up. And that's going to cause more issues. Does that answer your question about heart attack versus heart failure? Perfect. The uh, the other question that we had is, can we go over the beta 2 agonist mechanism? And of course we can. Do I go over it later on? I feel like I had a picture in here somewhere. Maybe not. We can go over that. I put in a ton of pictures last night for this, and apparently it did not stay. So thanks, Google Drive. Let me just grab my notes. Oop, there we go. Whoops. I just want to. Sorry. Um, no, we'll use this. Okay. Sorry. All right. So the beta 2 agonist mechanism is that we have the beta 2 receptor on the surface of a cell, which is a GPCR, and it's a GS coupled GPCR. And this is what GPCRs look like. They look like this funny spaghetti worm. And what happens is that our beta 2 agonist comes in and activates our uh, beta 2 receptor. Oops, I want to make sure that I get this right. The only thing worse than not getting it right is getting it wrong. And what we know from the activation of the beta, from the GS coupled receptor, is that this is going to lead to ATP. So this is going to stimulate the conversion of ATP into cyclic AMP, or CAMP. And what CAMP does is CAMP comes along and activates an enzyme called PKA. And so the way that it causes the smooth muscle, so let me back up. Let me get organized here. This is the direct effect of beta 2 agonism. What happens from here is that you remember that in smooth muscle, the way that contraction happens is we have, our calcium channel on the surface of the cell. Calcium flows into the cell, which then couples with the calmodulin, and this eventually stimulates MLCK, which is if you remember, it's that myosin light chain kinase, which then eventually leads to the myosin filament grabbing, and we have that whole contraction of the muscle. So remember that this pathway in green is how muscle contraction happens. And so what happens with beta 2 agonism? Our beta 2 agonist comes in, it stimulates the conversion of ATP to CAMP, and that CAMP stimulates PKA, and PKA inhibits MLCK. And if we inhibit the MLCK, then we inhibit the contraction. And by inhibiting the contraction, we cause dilation. Does that make sense? Perfect. Sorry, it was a bit more of a process than I had wanted, but we got there in the end. Me trying to find my notes. All right. So once again, we have 8 different beta 2 agonists, and their primary indication is for that asthma or COPD. And I just want to point out there's a drug called terbutaline. And terbutaline is used for the tocolytic effect of the beta 2 agonist. And so the what happens is that the terbutaline uh the this shouldn't be preterm abortion, it should be preterm birth. Oh, no, no, no. What happens is tocolysis is the process of preventing the sorry, I'm my bad. Tocolysis, I'm getting all flustered. Tocolysis is the prevention of uterine contraction. So if you had a woman who is pregnant and she starts going into early preterm labor, and we want to prevent that uh, birthing of the baby, then we can administer terbutaline, which will prevent the contractions. And so this leads to it stops the preterm birth of the baby. And then that's its usefulness for terbutaline. The last thing to note uh, about the beta 2 agonists is we should really take a look at their contraindications and really take a look at why they are contraindicated, why hypertension, incontinence, and glaucoma are contraindicated. Well, let's take a look at and try to figure out why hypertension, HTN, is contraindicated. Well, we learned up above that when you administer the beta 2 agonist, this leads to a drop in blood pressure. And the body responds to that initial drop in blood pressure by increasing the heart rate. And what that's going to do is it's going to raise the blood pressure back up. And so beta 2 agonists are contraindicated in someone with hypertension because we're going to be messing with their blood pressure. And we're going to be raising it to potentially a very dangerous level. Same thing with incontinence. Incontinence is the inability for the person to hold in their urine. And this actually has more to do with, I believe, the beta 3 receptor. Oh no, I think it's the relaxation of this. Okay. And essentially, uh, what happens in the bladder is if this is the bladder, which leads to the urethra, you have a series of sphincters that you can use in order to clench and prevent the flow of urine. And so, what happens when we administer that beta 2 agonist is that we relax the smooth muscle on the sphincters, as well as relaxing the smooth muscle in the ureter, not the ureters, in the urethra. And what that means is that we uh, increase the outflow of urine. Outflow of urine. And so this can mean that someone has a tough time holding in their urine, controlling their urgency to urinate. And so we wouldn't want to administer a beta 2 agonist to someone who already has issues with this because we just make it much worse. And lastly, the last contraindication that was listed there, whoops, not I, is glaucoma. And if we remember what glaucoma is, it's the accumulation of the aqueous humor in the front of the eye. And if I can draw a little diagram. And what happens is that this aqueous humor collects in the front of the eye, in front of the lens, and this puts lots of pressure going backwards because there is some sort of obstruction which prevents it from flowing to the canal of Schlemm. And so, what administering a beta 2 agonist does is that this increases aqueous humor production. And so, if we increase the aqueous humor production, we're going to increase the I'm going to say intra-eye, I forget, intraocular, probably, intraocular pressure. And what this is going to do is it's going to worsen someone's glaucoma. And these are the three major contraindications for beta 2 agonists, and we can start to see why. Any questions on these three contraindications? Perfect. What we're going to do is let's take a look back at the mechanism real quick. And obviously, when we look at this mechanism, we can't have camp being produced over and over and over and over and over again, right? We have to have some way of getting rid of camp in order to stop stimulating PKA and to stop causing the smooth muscle dilation. And so there is an enzyme called phosphodiesterase I'll write that out. Phosphodiesterase. And what phosphodiesterase does is that it breaks down CAMP into its different metabolic products. So what PDE does is that it decreases the level of CAMP, which then decreases the level of PKA, which then allows for muscle contraction again, smooth muscle contraction. And so this brings us to our next class of drugs, which are the phosphodiesterase inhibitors. And just like what we said, is that here we have our beta 2 receptor, or I guess any receptor really. And our ATP is converted into CAMP. And that CAMP would normally cause all of our different effects, like that bronchial smooth muscle relaxation. And later on, we'll talk about these other effects, but what we're going to focus on is that smooth muscle relaxation. And what happens is that you can have phosphodiesterase, which there are many different kinds of phosphodiesterases. And by normally, phosphodiesterase breaks down CAMP, which would decrease its concentration. And so what we can do is we can administer a phosphodiesterase inhibitor. And what that phosphodiesterase inhibitor does is that it blocks the phosphodiesterase. And so we can look at what the downstream effects of that would be. So normally we'd have lots of CAMP. CAMP would then increase smooth muscle relaxation. And CAMP would be broken down by phosphodiesterase and break it down into its metabolic into its metabolite. And so normally the levels of CAMP will go down, which would then decrease smooth muscle relaxation. So what happens is if we administer a phosphodiesterase inhibitor, this will increase the level of CAMP, which will then increase, let me put it this way. Administer the phosphodiesterase inhibitor, which prevents the breakdown of CAMP, which then increases the levels of CAMP, which ultimately leads to an increase in smooth muscle relaxation. So what's important to know about the phosphodiesterase inhibitors is that they work very similarly and cause very similar effects to the beta 2 agonists. So they're very similar. And we have two drugs that are general phosphodiesterase inhibitors. They inhibit a lot different ones. And then we have roflumilast, which is a phosphodiesterase 4 inhibitor. So it's more selective. And if you look, they're both indicated for the same thing as the beta 2 agonists, that asthma and that COPD, because they're going to cause that bronchodilation.
I am curious how this phosphodiesterase is related to CAMP.
How it's related to CAMP?
Yes.
So, phosphodiesterase is an enzyme. So, it's this big enzyme. And all it does is it takes CAMP and it breaks it down into its metabolite. And so that's the relationship between CAMP and the phosphodiesterase. And what you should be reminded of is that this is very similar to another kind of esterase, which is acetylcholinesterase, which takes acetylcholine and breaks it down into its metabolites. And so, much in the same way that we can administer, much in the same way that we can administer a acetylcholinesterase inhibitor, which will cause an increase in acetylcholine, we can administer a phosphodiesterase inhibitor, which also increases the concentration of CAMP. Does that answer your question?
Yes. Thank you for the clarification.
You're welcome. If we look at the adverse reactions or the adverse effects of the phosphodiesterase inhibitors, one of the big things that we'll find is tachycardia. And the question becomes, we should always be asking ourselves, well, why is this happening? And what we have to remember is we have to look at what the effect of the drug is, right? We administer a phosphodiesterase inhibitor. That phosphodiesterase inhibitor causes smooth muscle relaxation. And that smooth muscle relaxation could be around the uh, the vascular system, so it could be around our blood vessels, and we could have dilation of the blood vessel. So just like what we saw with the beta agonists, you administer a PD phosphodiesterase inhibitor, and it causes dilation of the blood vessel. And what did we find with the just like the beta 2 agonists? Well, we found that that initially dropped your blood pressure. And we said that that drop in blood pressure causes a reflex tachycardia. And so this is why one of the major adverse effects, one of the adverse reactions of phosphodiesterase inhibitors is tachycardia. Because we're widening the the blood vessels, which is dropping our blood pressure, which is then causing that reflex tachycardia. Another side effect that we can get is dizziness. And again, this comes directly from this decrease in blood pressure, is that this can cause hypotension. And that hypotension can cause the patient to become dizzy. And then over time, as the heart starts to pick up in heart rate and starts to beat faster, we start to get more and more, the patient will get less and less dizzy. But definitely one of the bigger effects when someone takes the phosphodiesterase inhibitors is that hypotension. So just pointing out uh, two of the big um, side effects for us. And so when you go through the class in the fall, this is one of the big things that you should be doing is you should be sitting down and saying, okay, why do the adverse reactions, the adverse effects exist in the way that they do? Cool. Uh, Now, with that being said, we have learned a lot of drugs that can all be used for asthma and COPD. And so what I've done here is I've kind of compared and contrast some of these drugs that we've gone over before, the beta 2 agonists, the phosphodiesterase inhibitors, and then also those antimuscarinics that we've learned before. And what's important to know here is that the antimuscarinics which work here on they increase the amount of acetylcholine or they increase the parasympathetic tone. Sorry, my bad. Whoops, let me back up. The the we sorry, let me start here. We learned that the beta agonists, the beta 2 agonists, activate and produce more CAMP. And we learned that that CAMP then activates PKA, and that PKA prevents the muscle contraction, which eventually leads to bronchodilation. We also learned that phosphodiesterase inhibitors like theophylline block the phosphodiesterase, which prevents the breakdown of CAMP, which then increases the levels of CAMP, which then activates PKA, which then prevents muscle contraction, which then causes bronchodilation. Now, previously, if we think back to our antimuscarinics that we learned before, there are two antimuscarinics that are commonly prescribed for asthma and COPD, and that's ipratropium and tiotropium. And if you remember, muscarinic antagonists, block acetylcholine. And by blocking acetylcholine, we're going to prevent bronchoconstriction. And by preventing bronchoconstriction, we're going to cause bronchodilation. Very cool. Any questions on this slide? Because this is a really big one that connects all this together. Very good. So this brings up the question of beta 2 antagonists. And The short answer is there are no beta 2 antagonists that are being used on the market. And the question becomes, well, why do we not have beta 2 antagonists? And the reason is because there's no situation in which they would be useful. We A beta 2 agonist causes vasodilation. So an antagonist would cause vasoconstriction. An agonist causes bronchodilation. So an antagonist would cause bronchoconstriction. And so we would never want to cause bronchoconstriction in a patient. That would just make it harder for them to breathe. And there's no situation which we would want a patient to have a harder time breathing. And then likewise, we didn't really talk about these metabolic effects, but in the same way that we don't want to cause vasoconstriction and we don't want to increase or decrease glucose production. We have better pathways for causing vasoconstriction, which can be useful in some ways, and also decreasing glucose production. And beta 2 antagonists are not the way of doing it. So, what's the primary reason? Well, the primary reason is we'd never want to cause bronchoconstriction. And second is because all the other effects, we have much better ways of doing it. And so that's what you should take away from the beta 2 antagonists. Very cool. All right. I want to talk a little bit about the. Okay, we'll be fine. Yeah, we can talk about this. We have about 20 minutes left. We can go over it again if we need to. Which slide was I on? This one. All right. What we're going to do now is we're going to shift gears and we're going to talk about the beta 1 receptor. And if we go back to our slide that compared the beta 2 and the beta 1 receptor, is that the beta 1 receptor is found on the heart and the kidneys primarily. It's still GS coupled GPCR. But what we're going to find is that it's going to lead to a different response in the heart than what we would be expecting. So the beta 1 receptor, what's important to know about the beta 1 receptor is that it makes the heart contract harder, it makes it contract more often, and it's well, we'll talk about downregulation in a second, but these are the two big things to bear in mind. Is that agonism of the beta 1 receptor makes it beat harder and makes it beat more often. And so if we make the heart beat harder and we make it beat more often, then we can think about what effect that's going to have on blood pressure. And so the major effect of using a beta 1 agonist is to increase heart rate. Now, I hear you saying, well, whoa. You know, didn't we just talk about all this time about uh you know, we causing an increase in heart rate is bad because, that can be bad for the heart? Well, it is right that we wouldn't want to give a beta 1 agonist to someone with heart failure or someone with tachycardia or hypertension because, you know, this increase in heart rate is going to increase the blood pressure. So we would not want to give a beta 1 agonist to someone with heart failure or hypertension or tachycardia, but we would give it to someone with bradyarrhythmias. So if someone's heart is beating too slow, then we can give them a beta 1 agonist, which will increase their heart rate and start to increase their blood pressure. Likewise, we can give it to someone who's in cardiac arrest. Which means that the heart is not being stimulated as much as it should be. And so this will cause an increased stimulation of the heart, which will increase its heart rate and will help the person's blood pressure bring them back. So that's what the effect on the heart is. The beta 1 agonist also has an effect on the uh, the juxtaglomerular cells in the kidney. Glomular? Glomular? Granular? I believe. Glomerular. There we go. Juxtaglomerular. Which from now on I will be referring to as the JG cells. So what happens is, if you remember, the JG cells are responsible for releasing renin. Oh yeah, remember back to patho, the renin aldosterone angiotensin system? Oh god, right? Oh geez. So so if you remember, the downstream effect of renin is that it increases vessel constriction. That the the downstream effect of renin is that it increases vessel constriction. Vessel constriction? I don't think it does that. I believe it increases the amount of water that's reuptake. So what I'm going to say is it increases blood pressure, because ultimately that's what it does. So what a beta 1 agonist does is that it stimulates the increased release of renin. And so what this is going to do is it's going to increase the blood pressure. And so one of the major uses of using a beta 1 agonist is for someone in shock or when they're hypotensive. So we can give someone a beta 1 agonist, which will increase their blood pressure and take them out of shock. And so when we look at the effect of the beta 1 agonist, we start to see an increase in heart rate, an increase in contractility, an increase in the stimulation of the heart, and then we get an increase of renin release, which then ultimately, all of these effects increase blood pressure. And so what we find is that we only have one drug that is a beta 1 agonist, and that would be dobutamine. And so when we start to look at the indications, what we can see is that the uh, dobutamine is used for those bradyarrhythmias, or for uh, sorry, it's used for those bradyarrhythmias, or for when the heart is beating too slow. We talked about when the dobutamine is used for cardiac arrest, or when the heart isn't beating enough. And then we also talked about when the 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 dobutamine would be used for the um, sorry, would be used for shock, because it would increase the amount of renin that's released, which would then increase blood pressure, which would then take someone out of shock. Any questions so far? Perfect. Now, one of the big things to understand about dobutamine is that over time it becomes less effective. So on the first day, it's very effective. You're increasing the heart rate significantly. You're causing the heart to beat faster. You're causing it to beat stronger. But then as you keep giving it more and more and more, we start to uh, see a decreasing effect. And what we find is that on the myocytes, which have this beta 1 receptor, what we find is that over time, as we keep giving more and more dobutamine, let me draw another one. Beta 1. What happens is that uh, the number of receptors on the cell surface goes down. And this process is called tachyphylaxis. Or in other words, is that the receptors downregulate. So what happens is that these receptors start to move inwards away from the surface of the cell, which prevents them from being stimulated. So they move from the outer to the inner membrane, and they can't be stimulated at all. And this is what leads to the diminishing effect of dobutamine. It's because after a few days, there's less and less receptors for it to be stimulated, for it to stimulate, I should say. And so this brings up the question, well, why is it useful in heart failure? And the reason why dobutamine is helpful in heart failure is because heart failure is all about overworking the heart. The heart is working too much. And so, what we can do is we can administer dobutamine, which will cause this down regulation of the beta 1 receptor, which will then decrease the stimulation of the heart. And so, we'll be helping heart failure by making the heart more resistant to stimulation. So, let's say that again. So, over time, as you administer dobutamine, the beta 1 receptors move from the outer to the inner membrane of the cell, so they cannot be overstimulated. So, over time, the dobutamine becomes less and less effective. So, maybe we administer it to someone in the beginning for bradyarrhythmia, and then after a couple of days, their bradyarrhythmia comes back, or, initially their heart rate increases, they're looking really good. And then after a couple of days, their heart starts to slow down a little bit, and we're back to where we started. However, this idea of downregulation is useful in the idea of heart failure, which is where the heart is working too hard. It's working much too hard, and it starts to become weaker and weaker and weaker. And so, what we can do is we can administer dobutamine, which initially is going to skyrocket the heart rate. But then after a couple of days, the number of receptors starts to go down, and then the heart is less able to be stimulated, and so we are controlling the heart a little bit better. We're giving the heart a little bit of relaxation. And so that explains why dobutamine is useful in heart failure.
Could you actually explain what does it mean by like downregulate?
Downregulate? Yeah.
Mhm.
Let me see if I can find a nice picture. There we go. That's a nice picture. Can you see this picture?
Yes.
Perfect. So what this picture is showing is that we have our heart cell, and on the outside here we have our beta agonist coming in, which could be our dobutamine. And on the surface of the cell, we have our beta 1 receptor. And what happens is that all along the cell, you'd have multiple beta 1 receptors, lots and lots and lots of different ones. And so what happens is that if we stimulate this receptor too much, then the heart cell starts to engulf and engorge and internalize that receptor and take it away from the membrane. And so what that means is that uh, heart our heart cell won't be able to stimulate, sorry, our dobutamine won't be able to uh, uh, stimulate that receptor anymore, because now it's taken up inside the receptor. And so that receptor can then be destroyed and degraded by the uh, by the heart cell. And so as we keep stimulating more and more of these receptors, we're going to be decreasing the amount of receptors on the cell surface. And so what happens is that once we stop administering the agonist, the dobutamine, then the heart cell says, "Oh, okay, I can start to bring that receptor back," and it will put it back onto the cell membrane. But as soon as we start to agonize that again, it's going to go through the same process of internalizing and then down regulating it. And by down regulation, what we mean is that we are decreasing the stimulation of that heart cell. Does that make sense?
So it is kind of like when you down regulate, that means it's going to be internalized and gets into into the V1 receptor, and then it's going to be degraded, which means it's going to be destroyed into the her cell, and that's the way that the vitamin will be decrease the stimulation of the heart.
Exactly. So what happens is that more and more of these receptors start to get internalized. And so we start to have less and less of them on the cell surface. So when our dobutamine comes along, normally there would be three of them for it to interact with, but over time they start to go away and only one is left. And that's what the downregulation is that we have less receptors to stimulate over time. Does that make sense?
Yes.
Perfect. Perfect, perfect, perfect.
Mhm.
All right. So I believe that's where we'll leave it for today. And the next time that we'll meet, we'll start with the beta 1 antagonists. And then we'll talk about some of these other funny little guys, as well as our mixed beta receptor drugs, because not every drug is nice and then is selective for only one of the receptors. A lot of the drugs, like like a lot of the drugs that you've seen on your top 200, are actually um, non-selective. But we'll get there on Monday.
Okay, I actually want to ask you one more thing.
Sure.
So, um, if I enter one receptor and dopamine is while you're having the V1 receptors and then having the tachyphylaxis, and that's the same thing with the downregulate, right?
Correct. Yep, they're the same
So,
thing.
if you're gonna have the downregulate, it's going to be just internalized. And how do you destroy the B1 receptors then?
How do you destroy them?
Yes.
So what the body does is that the body says, "Oh, this receptor is being stimulated too much. There must be something wrong with it." So in order to prevent that stimulation, it uh, endocytosizes it. It brings that receptor into the cell and then breaks it down inside of a lysosome, and then it takes those parts and uses them where it needs to.
Okay,
So
so one third thing is like because there's too much, so it's going to be, yeah, breakdown
correct. So
B1 receptors will be.
essentially, the way to think of it is this beta 1 receptor is kind of like a button, and the dobutamine is pushing it too much. Push, 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 push. So what the heart cell does is it says, okay, we need to get rid of this button because it's being pushed too much. And so we'll internalize the receptor, which then prevents the dobutamine from stimulating as much.
Yes. Okay. Thank
And
you.
you're welcome. And then I believe there is uh one other picture I had. So what I'll do is I'll put the pictures into back into the PowerPoint, the ones that we used. And then put little explanations like I normally do with everything. Should be good. Cool. All right, let me stop this recording.